I'd like to introduce our speaker, Courtney Giannini. Courtney is a licensed clinical psychologist in the Department of Pediatrics at Norton Children's Hospital, serving as co-director of the Pediatric Consultation Liaison Service and is on faculty as an assistant professor at the University of Louisville. She received her Master's of Science in Clinical Psychology and a PhD in Clinical Psychology with a Pediatric Behavioral Health emphasis from Palo Alto University. She completed a pre-doctoral internship at Geisinger Medical Center in Pediatric Integrated Primary Care and on the Inpatient Consultation Liaison Service. She then completed her postdoctoral fellowship on the Psychiatry Consultation Service and Solid Organ and Multivisceral Transplant teams at Boston Children's Hospital, affiliated with Harvard Medical School Department of Psychiatry. So welcome, Courtney, and she will be talking to us about pediatric anxiety and depression, assessment and intervention. And I'll turn it over to you, Courtney.
Thank you so much for the introduction. It's nice to meet everyone. I was really excited to be able to do this talk. It is an incredibly broad topic, so my goal is really to talk about things that are relevant to medical providers, particularly in integrated care settings. And I know we'll have lots of time for questions at the end. I do always like to highlight that I am a psychologist, not a psychiatrist. And the primary difference being I did not go to medical school, so I cannot prescribe medications. But anecdotally and with my training, we deal with a lot of psychiatric medication related things. So happy to answer those questions as best I can if they come up. So first, just kind of want to give us a little roadmap. So I'll talk about the background of just anxiety and depression in pediatrics, diagnostic considerations, screening tools, and what we can do in a multidisciplinary approach, and really a big focus on evidence-based treatment. So start with depression. So I kind of like to think of this as pre, during, and post-pandemic. So depression really used to be kind of 1 in 5, if we're thinking about it. And in pediatrics, there was a massive increase just with the rest of the world during the pandemic. So by 2020, I mean, 2.4 million kids have been diagnosed with depression, which is no small amount. And then that really jumped quite a bit to 1 in 4 in after the pandemic. So definitely a major increase, a very large need for screening and intervention. And we'll get into that in a bit. Anxiety really followed a similar pattern. It's actually also a condition that is pretty underdiagnosed, actually. So thinking about, as we introduce diagnostic considerations and screeners, how can we detect it earlier? Because as we know, preventative care is really the bread and butter to everything and can make it a lot easier to treat things in the future, especially with all the comorbidities that come with a lot of these conditions. So I really want to spend a lot of time talking about diagnosis. So in the psych world, we lean into our DSM, or the Diagnostic and Statistical Manual, and we're on our 5th iteration with a revised copy. And there are different schools of thought when it comes to diagnosing. I would say the biggest thing here that I've seen is in regards to billing. So thankfully, at Norton Children's, in the psych world, we're able to bill H&B codes, or health and behavior codes. So we can go in and do an assessment without needing a diagnosis for reimbursement. Now, a lot of places aren't so lucky to have health and behavior codes, and they're more in the traditional CPT realm, in which case they're kind of required to have a diagnosis to be reimbursed for billing. So that can come up with a lot of ethical dilemmas in that sense, to diagnose or to not. Again, thankfully here we aren't pushed into that bubble, which is very nice, and we can be pretty thoughtful about doing that, because there's a lot of stigma that can come with diagnosis, and so want to be cognizant of that. So the biggest things here are, if you take anything away, Anxiety and depression are different than a major depressive disorder and generalized anxiety disorder. So the other thing, if you look on my bubbles here, there are lots of bolded fonts. So there's about 5-ish criteria that are relatively, if not the same, diagnostic criteria. So we really want to be thinking about what differentiates depression and anxiety and the disorders themselves. So the biggest things with major depressive disorder is low mood, or anhedonia is another word for having really no interest in the things that used to bring us joy anymore. Whereas in anxiety, there's not necessarily that low depressed mood. It's more, hey, we're having generalized worries about lots of different things. And then psychomotor agitation or retardation, so that kind of fidgety restlessness, which applies to GAD as well, but retardation, that slowness, is more of a component of MDD versus GAD. And then another thing is I put a little asterisk here on low mood. In kids, it's not necessarily always low mood. A lot of times it actually presents as irritability, which then is also a part of GAD. So you can see how this can get pretty muddy, and we want to be very cognizant of trying to differentiate between the two. And then the other big difference is suicidal thoughts or just thoughts of death. And something we use here, again, screeners to help determine severity, but especially in little kids, they don't necessarily understand the difference between like a truly suicidal thought versus curiosity about death. So this can be something for clinicians to be thinking about, like if a little kid was like, oh, I've thought about riding my scooter into traffic. Have they actually thought about that? Or has it been, oh, I wonder what would happen if I got hurt? I wonder what would happen if I wasn't here anymore. Would someone not love me? Would my parents would be around? So being able to teach them what the difference is very important. I would say rarely do I have the littles, kids under 10 presenting with those kinds of things. Have I seen that before? Yes, I have had younger kids who have genuinely had suicidal thoughts, and it is a big risk factor and it can be incredibly sad. But we do want to make sure that they are educated, and there is a way to educate little kids on a lot of really big things. The other big components with differentiating these disorders is timeline. It can be very helpful, and just number of criteria, like per the DSM, for checking boxes. So with depression, you only need to have 5 out of these 9 for 2+ weeks. It's really not a lot of time, versus an anxiety disorder is, hey, you need to have 4 out of 7 for over 6 months, right? So we want to see a consistent pattern, and both of these are, yeah, we're experiencing these symptoms all day, most days, rather than, oh yeah, once a week, I'm feeling kind of tired, or maybe once a week, it's just really hard to focus in school, or maybe there are some other things going on. So diagnostically speaking, the big takeaways are these have a lot of overlap, and actually about 75% of people who have one or the other, there's a comorbidity and they have both. It can be kind of chicken or egg. And then other big things, differentiating wise, anxiety, think hyperarousal, right? That fight or flight process. With depression, you can think more hypoarousal. So that can help differentiate between the two. If I could say one thing about all of these disorders, or really any psychiatric disorder ever, functional impairment. Is it getting in the way of their normal life and activities? Right? Like I said, being anxious does not mean an anxiety disorder. Being depressed does not mean a depressive disorder. Anxiety and depression are human emotions that everybody feels. Anxiety is designed to keep us safe. It's our internal alarm system. It's supposed to work. We're supposed to feel anxious in certain times. It's when we start to have it in overdrive and it's getting in the way of everything, right? When we have those kids that can't go to school because their stomach hurts so badly and it's in knots because they're so worried about their presentations and being able to stand up in front of the class, or social scrutiny, or they're worried about school and sports and their family to the point that they can't get anything done and they're absolutely frozen. That would lean more towards a disorder versus just kind of normal anxiety. So really thinking about, and when you're asking questions, is this getting in the way of your everyday stuff, right? I've definitely got some really anxious nuggets and they're that way at baseline, and often we have a genetic component. You meet their parents and you're like, oh yes, the apple does not fall that far. However, are they able to actually go throughout their day? So important considerations, rule outs. As providers, cross specialties, and it's a pretty broad group of humans, thinking about okay, well, what are all the contextual factors that might actually lead to some of these conditions? So first, big one, substance use. We see that a lot, and I could do an entire talk on cannabis use, but I don't have the time for that. So thinking about okay, are they vaping? And what are they vaping? If they are, that's always the big question. Do they even know what's in it? Because often it's off the street. It's got a mix of nicotine and cannabis and other things. And how often, how frequently are they using, that kind of stuff. And then we want to think about withdrawal as well. Did they stop using and now they're having behavioral changes? Or were these behavioral changes and mood changes actually happening pre the substance use, right? And then it actually led to substance use. Medication effects, think of Benadryl. Some people, it doesn't make them sleepy, it actually makes them really amped up and agitated. So are there anticholinergic effects that are happening that are causing severe amounts of, in this case, anxiety? And it's in the context of that rather than, hey, I have this pre-existing anxiety that's coming from a lot of different areas. Trauma or adjustment. If there's one thing that could describe almost everything, it's trauma. Often there is a kind of what we call an apex trauma, or a primary event thing that happened that then is causing a lot of trauma symptoms, or it can be exposure to kind of little t traumas over time, and that can compound. Just because someone experiences trauma doesn't necessarily mean that there's a trauma disorder. Again, that kind of differentiation, but considerations for what might actually be causing depressed mood or kind of an anxious temperament is there divorce, right? That is a very big thing, and trying to adjust back and forth between homes or schools, and over the summer, do parents live in different states? That's a lot of work for a little kid, or honestly even teens. They need routine and consistency, and that always impedes that. Transitioning to high school, that's a big one, especially our kids who are very perfectionistic, very academically oriented, strong in sports. They're trying to be little adults, and it's a lot. And abuse history, that's really, I think, a big one, trying to be cognizant of that. And that's something in our world that we're always screening for, just to check. Next, medical illness. Always doing kind of a workup. Again, thinking about the timeline of things, right? Has this depressed mood and depression symptoms been presenting just in the last 2 weeks? Has it actually been unchecked for the last 6 months or the last year? Hypothyroidism is always the big one that can cause that. Adjusting to diabetes, mood changes, we definitely see that in the hospitals. We see a lot of new onset type 1, and kids are in DKA, and we really find that even though they're presenting like they might have major depression, it's actually related to unmanaged diabetes. And then bereavement. did someone die? That's a big question. How's it going with their family? Did they have a close relative? We see a lot of kids who maybe they had a grandparent who was really a primary caregiver or just a really good source of support in their life that they lost within kind of the last 6 months. And they've had a really hard time adjusting to that. And maybe the family hasn't necessarily had a lot of education on how to talk to kids about passing or pets dying. I'm sure we've all heard some pretty wild stories about how things get explained to patients and kids. So being able to screen some of these, and these are pretty easy to either put on questionnaires or just screen right when they come in. So in the realm of screening, let's talk about evidence-based approaches. You're going to hear me say that a lot. So it's first and foremost, a screener is designed to be kind of an initial gate into clinical inquiry or assessment, right? It's not a one time meets all, it's going to serve all your functions and needs. Thinking about that, sometimes screeners yield false positives. So ideally, we're looking at screeners that have strong psychometric properties, and I'll get into that a little bit more too, but ultimately being like, hey, what is the research on this? Making sure we're looking at up-to-date research, and if you don't have time or energy to do that, asking somebody who does. With these screeners that I'm about to talk about, they are both strong psychometrically, but they're really designed to start at age 12 and kind of go at 12 to 18. You might be able to fudge that a little bit younger, but you might have to walk through some of the items and explain them more readily to some of the kids, especially if they're a little bit younger presenting. But age 12 is really when we start to see a pretty significant rise in anxiety and depression rates. Prior to that, it's actually pretty low. But also at age 12, the ratio of girls to boys is actually 2 to 1. So it is really important to start the screening process at that age. And again, with the younger kiddos, you're more likely to see what we call externalizing disorders like tantruming, and have more issues with feeding, being really picky eaters. That's definitely a big thing that we'd see like in primary care. Sleep concerns, sleep schedules all off, toileting concerns like enuresis and encopresis. For example, you have kids who have megacolon, and so behaviorally we might help try to adjust their schedule and make sure they're being adherent to medications, those kinds of things. Ultimately, all of those kind of externalizing presentations, if they go unchecked, it's very likely that then they may develop anxiety or they may develop depression, because as things compound over time and they become really hard to handle, we end up often seeing kind of an anxious or depressive process result from that. So our first one is the PHQ-9. So the Academy of Pediatrics actually recommended universal depression screening for young patients ages 12 to 18. So the PHQ really fits that nicely. It's super brief, takes no more than 5 to 10 minutes, and it's very easy to use in primary care settings, hospital settings, you name it. And it has some pretty good psychometrics. So for fellow data nerds out there, the sensitivity, which is saying that there are few false negative results, so there's fewer missed cases of depression. So it's saying almost 90% of the time it's detecting that appropriately. The specificity is basically the ability to correctly identify an individual who does not have depression. And so not as strong as the sensitivity, however, anything really over 70-75% is good for a psychometric property of a screener. And then internal consistency is a component of reliability. So it's like the consistency of a measure. And so it's like in the same conditions are the same results being reproduced. So it's saying that a lot of studies have looked at this and it pretty consistently is detecting depression. So implementation, this is really important. The PHQ, what I love about it, is it's available in over 30 languages, which is amazing. It's also free and readily available with the manual, instructions, and translations at the website listed there. And it's something that's actually pretty easy to build out in your electronic medical record. So we're all medical professionals, we're very busy, don't have a lot of time. So having paper copies and needing to input all the data items, it just does take a little bit more time and energy. So being able to work with your electronic medical record, and at Norton we work with Epic, can be very, very helpful to reduce provider burn-in, increase the efficiency, and make everyone's life a lot easier. The risk component, when we think of depression, there is a concern for risk and suicidality. Number 9 on the PHQ is assessing risk. I could do an entire talk about just doing that, but more for provider ease. Another option for an EMR build out is the Columbia Suicide Severity Rating Scale. It is a very valid, reliable measure, and on their website, actually, Columbia's website, they have the safety protocol as well. So based on the scoring, there is literally a color-coded chart that says, okay, what's the level of risk and what do we recommend? Which again, that can also be implemented and put into Epic or used as a smart phrase. That's what I do, so it's easy documentation. So thinking about, okay, what do I do based on these results? So for the PHQ, really no depression, or is about 0 to 4. If they're indicating in the mild range, which is a score of 5 to 9, you want to be evaluating, hey, are there physical illnesses going on? What are some stressors in their life? Are they doing some of those transition things? Was there bereavement? Is there parent challenges in the home? Sibling discourse, those kinds of things. And bullying, that would be the other big one. But also just making recommendations about sleep habits, diet, stress management, like you could do at a normal well child visit. In the moderate range, that's where we want to start thinking about, okay, when do we get behavioral health involved? So you can initiate a referral if it's available in your clinic or wherever you're working, or do you have to refer out? And monitoring possible physical illnesses and psychiatric symptoms. There have been a couple studies that have shown that using a cutoff of 11 instead of 10 is typical for more of an adult population, but the 11 actually helped reduce false positive rates. So that can be another consideration, but they did say that if sticking to 10 was just easier, then that's also fine, but just thinking about, again, that consideration. And then moderately severe, that's when it's like, yeah, we want to get maybe a psychiatrist involved, and either just psychologist or behavioral health clinician. If they're indicating severe, that's where immediate initiation of pharmacotherapy may be considered. And if there's significant risk, then saying, hey, is this a time where we actually need to send you to the ED for an evaluation? And see if they need a higher level of care, which is likely, but again, not impossible. So next, think about, that was the depression piece, think about the anxiety piece. The GAD-7 is, again, a teeny tiny little screener that's got a lot of good power. Each of these scales use Likert scales. They're pretty easy to read. This also is for ages 12 to 18, typically used in adult populations, but has been shown effective from 12 to 18. If you really wanted to get crazy with it, for the littler kids, if you're really worried about anxiety, you can use something called the SCARED. If you'll just type in all caps SCARED into Google, a free version will pop out. It's about, I think it's 41 questions long. So it's a little bit more time intensive. However, it has a really good breakdown of the different types of anxiety, like separation or social, those kinds of things, which can also be implemented into EMR. But for ease and being able to detect degree and severity of anxiety, the G87 works quite well. So again, some more data on that. So its sensitivity is a little less strong than the PHQ for comparing to, detecting or having fewer missed cases, but strong reliability for sure. And it is pretty successful at being able to correctly identify people who don't have anxiety. Similar to depression, with thinking of kiddos and the cutoff point and where that is making it more sensitive or more specific, they were finding that a cutoff of greater than 10 increased that number to 89%, whereas with lower than 10, it was actually around like 80%. So another consideration is just upping the cutoff. So again, thinking about implementation, available in many, many languages, also free online, which we love, very accessible. And these recommendations kind of in the tiered approach section, these are pulled from the recommendations for the PHQ. They're essentially the same. They're pretty consistent in their treatment approaches and what's needed. The only difference being like the level of risk and safety that comes with this. If someone has really incredibly high anxiety, do they need to go to the emergency department for an evaluation? Not necessarily. However, has it happened? Have I seen that? For sure. And have I actually seen kiddos with anxiety so unbelievably high and such an unchecked disorder that they actually needed an inpatient level of care to treat anxiety? Yes. So using your clinical judgment at that point, again, impairment of functioning. What is getting in the way? Are things getting in the way? And that can help you determine the level of care that's then required. So integrated care. Right? Research shows that approximately 90% of children visit a pediatrician within any given year. So thinking about how can we reach the most amount of people, it's typically in integrated primary care. Pediatricians are often serving in the front line of identifying and treating behavioral health concerns. And I think it was 50% of visits often involve a behavioral health component, and behavioral health visits end up making the time for that visit quite a bit longer. So being able to embed behavioral health into integrated primary care is actually incredibly helpful. When I was at Geisinger, I worked in primary care, and whenever it was flagged, we'd do warm handoffs, and the pediatrician would send us a quick little message being like, hey, got another one for you. We'd pop over to their office and actually take over in that visit so the pediatrician could then move on, and we can do a risk assessment or a screening and then determine what level of care they needed. If you don't have psychological service embedded in your office, then it could add a little bit more time, but by using these evidence-based screeners, you're actually able to then very quickly determine recommendations. It takes a little bit more work on the forefront to implement some of the infrastructure for it, but it is actually very helpful. So thinking about like, what do you see and what can kind of be the process? So first, I want you to assess. Is it psychiatric or is it actually a primary medical problem, right? Like, is there a family history of diabetes? What do their growth charts look like? Is there hypothyroidism? Any concerns like that? Doing a thorough medical workup. Honestly, it could be a little more time intensive, but it could save you a lot of time on the back end, especially with our anxious parents who have a lot of questions. So being able to point and say, hey, actually, we're good. We'll monitor if we need, but we've done our due diligence. Screening. So again, the PHQ-9, the Columbia, and the G87. I can't stress enough getting these into your electronic medical record process. It will make your life so much easier. Just click a bunch of buttons and then it's done and it's logged and tracked already. And if you get really fun with it, then it can have it produce recommendations as well based on scoring. And then referring. It's very, very helpful, little plug for psychology, to have our medical partners really advocate to have us in the medical spaces. We love that. Well, I love that. Can't speak for the rest of psychologists, but I love that. And so being able to partner with you and say, what do you need? How can we help? How can we make your life easier? That's really how I view my role. And so being able to have us embedded into clinics and have a lot of people say, hey, we need you, that will make your life a lot easier. And then those referrals you can actually do in-house rather than having to refer out, which does take a lot of time and can slow down the process, especially with the patients who have a little bit higher of acuity. Access to care, especially in the state of the world, is a bit challenging, especially with pharmacological approaches. There is definitely a shortage of psychiatrists, let alone child psychiatrists. So thinking about different strategies for helping increase access to care. But when you're assessing, things you can think about asking: what do you do to help when you feel anxious? It's one question and you can see, hey, do you have any coping skills, or do you do nothing and you're absolutely frozen and you can't move? And what does get this feeling, or what does this feeling get in the way of doing, is another way of asking for kind of that impairment focused question. Evidence-based. Whenever you are referring and making behavioral health recommendations of any kind, we want it to be evidence-based. I cannot stress this enough. So a very wonderful website, again, free, easy to access, it's called effectivechildtherapy.org. Again, effectivechildtherapy.org. You can search by concern, symptom, disorder, or via the evidence-based treatment. But if you have no idea what the treatment is, that's the goal of this website. It's designed by the Society of Child Psychology, and really is just trying to increase access to care and having the correct language. So in that realm, the evidence-based approaches for major depressive disorder and a generalized anxiety disorder, really any anxiety or depressive conditions. Frontline treatment, cognitive behavioral therapy. That's not to say other therapies don't work. It's rather CBT right now just has the most data behind it. I know there are a couple others that are up and coming, and there's a lot of different kinds of CBT. However, at their root, they are all CBT. So being able to use that as kind of your plug word when making a recommendation, important. If there are providers available in your area, and even one step further from CBT is a modular CBT approach, because rarely does a kid or patient just have depression or just have anxiety. And so while CBT is incredibly manualized and very structured, a new phase modular approach allows you to kind of plug and chug, like, oh, they're depressed. Oh, well, is there actually a disruptive behavior also? Well, then do this instead. Is there a anxiety also? Well, now do this step instead, which helps just move the components around a little bit easier. But ultimately, just regular old CBT has a lot of strong evidence supporting outcomes. And then with anxiety, CBT is effective. The other treatment option is exposure and response prevention. And so especially for things like a specific phobia, saying, for example, I have a severe fear of needles, which is ironic because I work in a hospital. But being exposed to these things in a way that's scaffolded and safe really helps reduce anxiety and especially phobias, and then help doing response prevention makes it so that, oh, this isn't coming back. And then pharmacotherapy. With pharmacotherapy, for adolescents, the big study that was done in 2004 was the Treatment for Adolescent Depression Study, or TADS. It was kind of the iconic study, and it was really comparing CBT and SSRIs and combination treatment. So big thing is all of it works. That's the big takeaway. All of it works. SSRIs, however, have a faster benefit. So you're seeing symptoms reduce quickly. Whereas CBT takes a little bit longer to initiate, but it still actually does have a strong effect. Of note, I have SNRIs on here as well, just serotonin and norepinephrine reuptake inhibitors. These are typically helpful in especially treatment-resistant depression. So say someone has been through therapy multiple times, they've tried a bunch of different SSRIs, and really nothing is working. And you're like, okay, what else can we do? They may need an SNRI. Or is there a family history that SSRIs have really been unhelpful? I've definitely seen people start with SNRIs. With adolescents, SSRIs are kind of the frontline treatment, but still definitely an option. CBT, again, it's manualized. It takes 8 to 12 weeks, kind of depending on how readily they can get in. Say a psychologist is able to see you every other week or maybe once a month, that could extend the life of that. But it is a pretty set amount of time, and the goal is to initially establish, okay, what do we need to do here? What are our treatment goals? Being able to get a baseline of symptoms, and then your next phase is going to be symptom reduction through those cognitive and behavioral strategies. And then ideally that third phase is either a maintenance phase, or if it's not working, referring to a higher level of care, more med management, or adjusting and going again. So again, very, very structured, and exposure and response prevention is also incredibly structured, which can be very helpful. But the research shows that it does best when you have them together. So not only being able to have symptoms remit faster, but being able to extend the life, and so people go into remission. Within TADS, they showed that with their 36, 52-week and a year of follow-up, that ultimately the combined treatment groups were the ones that had the lowest rates of relapse. So really thinking about, okay, what is going to be the best option for this patient, for this family, okay? Considerations of access to care, right? If you're in rural Kentucky and maybe they don't have access to a psychologist, and maybe this kid doesn't have a lot of medical things on board, and if you feel comfortable prescribing an SSRI, that might be a way to initially access care, or vice versa. Maybe they have access to a therapist, they already have one, and they're able to do therapy and then sometimes people just don't like medicine. We see that a lot. A lot of parents don't want their kids to be taking psychiatric meds for one reason or another. So we know that both are effective, and best bang for your buck is ideally having both. And describing to families, this is not designed to be forever. Anxiety and depressive disorders are readily treatable, and it doesn't have to be a lifelong thing. If you have a major depressive episode, do you have a higher risk of having one again in the future? Sure. And if you get effective treatment and then have the coping skills, you're able then to identify what the risk factors are and what your red flags are, and say, oh, yep, oh, that's happening. Okay, yep, I'm highly likely I'm going down that rabbit hole again. What can I do to try and stop it in its tracks? Because depression naturally, I'll say that loosely, quote unquote, cycles, 6 to 9 months. People may kind of actually come out of a depressive episode, but if they have absolutely no skills to manage, they're way more likely than to have it come back because they can't read the signs or they didn't do anything to change their lifestyle. So I just gave you guys tons of broad information, but that's really kind of where I would like to wrap up and really jump into questions, because I think this is helpful to speak anecdotally how to manage individual patients if that comes up, or if anyone has any questions about implementation in clinics, or just outpatient settings, or even in hospital settings, I can definitely speak to that as well, or risk management, all those kinds of things. So lay it on me.
All right, thank you, Courtney.
Mhm.
Question, do you see a lot of antidepressant induced akathisia in your practice with the pediatric population?
I can't say that I do.
Okay.
I could ask one of our psychiatrists and see if they have any follow-up, and then have that disseminated to the group if that would be helpful.
Okay.
But that
And
specifically, no.
how much of your practice is integrated with primary care?
Right now, my current practice is not at all. I am only on the inpatient medical setting. However, I've done a lot of training fully integrated into primary care, and that's like my primary location in the office. So,
Okay. And then how long does it take to get someone an appointment with you all for psychology? A patient.
within Norton Children's, you have the Bingham Clinic, which is really our outpatient clinic. With them, because we have psychology and psychiatry trainees embedded, I believe people can actually get in fairly quickly, than a couple weeks, couple months. But as far as out in the community, that is very much kind of a TBD, because as we know, patients trend and how busy things are. So.
Okay. All right. And how do you best talk with pediatricians who do not want to screen for depression despite the need?
Great question. Data is your friend. Thinking about, okay, how am I saving you time? How am I saving you money? Those are everyone's love language. And so how do we do that? So doing a quick data poll, doing a little lit review, that can be very, very helpful. And yeah, I think that's what I found to be the best in. And then yeah, time the EMR as well, being able to do that and put it on, I don't want to say put it on nursing, but it's as you're like rooming patients, just doing like the quick screen and asking the questions. It takes a couple minutes. That's another way of saying like pediatricians, it's not necessarily on you to be doing the screen. But if something is flagged, then they can maybe address it.
Okay. And what are your thoughts on screening when a child is ill? Should you wait until they're well?
That's a really good question. So I think 12 and up, there should be a general screen just across the board. You don't want to miss something. However, in that assessing piece, right? Say they flag and they're fatigued, they have low energy, low mood, not sleeping well. Did that just start when they got sick? Is that aligned with that timeline? Or is it actually happening before then? It's just gotten worse because they've been sick. That's kind of that interview piece that can be helpful, but I think everybody should be screened.
Okay, and do you screen parents for depression or anxiety if the child is positive?
So it can be worth getting a family history and seeing if they're actively experiencing that or not. As far as doing a formal screen, like a PHQ, something like that, I think there's some debate on whether or not to do that, because you, in theory, say you gave a parent a PHQ-9, you would need to document that. If the parent doesn't have a chart with you, it can be a HIPAA violation to be documenting their mental health in a child chart. So I would say more of a verbal, hey, is there a family history of depression? Yes. Oh, okay, cool. Does anyone take any medicines? What might be helpful? Because genetically, say someone is taking, their parents taking Lexapro and they find that to be really helpful, that might actually be a good starting point for a provider versus trying something else.
Okay, and if a screen is positive in a child, how often do you rescreen?
Good question. Usually it's every couple of weeks. You could do at a follow-up visit, and I would say depending on the severity would depend on when they need to be seen again, especially if there's no follow-up with some sort of like behavioral health provider. If they have a higher screen, even if it's just like a quick video check-in to be like, yeah, how are things going? If you decided to go with the medication route, what's important to know with those is it takes 4 to 6 weeks for you to kind of titrate up the dosaging, and then it can take months to find the right dose and maintain that, and then ideally they're on it for about a year to really get the full effect. So if med management is especially involved, following up on side effects, is it affecting their sleep? The other thing is, I know parents get very worried about, is it going to increase suicidality? There was, with the initiation of black box warnings, and when that ended up getting on labels, it freaked everybody out. It honestly is fairly rare for those medicines to actually have an increase in suicidality. It does happen, but that's another thing to kind of be monitoring and educating as well.
Thank you, Courtney. You've answered all our questions.